कसं चालू आहे? पाऊस
तर
जोरात आहे. विदर्भामध्ये खूप जोरात पाऊस आहे
हो,
सध्या.
खूप जास्त, खूप. आणि मला वाटतं 10 दिवसापासून ऑलमोस्ट नॉनस्टॉप आहे.
Very good afternoon. We are live and we would like to start the meeting. A very good afternoon, respected seniors and dear friends. I extend a very warm welcome and heartfelt season's greetings to you all. The AMOGS High Risk Pregnancy Committee is really very happy to present before you part 5 of Code Blue PPH comprehensive series, and we are marching towards the conclusion part of it. This part is presented with the great help, technical support of COR Connect Corona Remedies, and it's a great honor to be associated with AMOGS Medical Disorders of Pregnancy Committee for this webinar, along with Emergency Obstetrics Committee, Website Committee, and Amravati OBGYN Society. Next, please. एकच ध्यास आणि तो म्हणजे AMOGSचा विकास. Yes, I'm talking about none other than our beloved and most respected AMOGS President, Dr. Pardeshi sir. He is a chief guest today, and he is constantly encouraging and supporting us in all our endeavors. I want to request him to address the webinar today. I welcome you.
Good evening, everybody. Thank you, Dr. Rashmi, for kind introduction. Dear Dr. Sujata Dalvi, Dr. Rashmi Kahar, Dr. Sneha Boyar, Dr. Chaitanya Shembekar, Dr. Pranjal Sharma, Dr. Suyoga, Dr. Anita Bobde, and Dr. Rajashree Sengupta. Thank you so much again for making me a part of this webinar on PPH. This is really a divine program, I say, as it reduces the maternal morbidity and mortality. I congratulate specially to Dr. Rashmi Kahar, our overactive, because in this she has taken nice step for this initiative in PPH. And of course, other committees are also helping, that AMOGS Medical Disorder Committee, AMOGS Emergency Obstetric Committee, AMOGS Website Committee, and Amravati Society. This is really a practical webinar, and with the galaxy of speakers and chairperson, I think this will be a great program. I don't want to be in between you and scientific content. I wish every success to Dr. Sneha Boyar for our future endeavor in FOXY, and I wish every success to this webinar. Thank you so much. Thank you.
Thank you so much, sir.
Thank you very much, sir. Thank you very much, sir. Our next chief guest of honor is Dr. Sujata Dalvi, madam. Madam actually needs no introduction. The demure, petite, and loving, most supportive, kind, and helping woman. Madam is our secretary of AMOGS. We welcome you, ma'am. I think she is busy in patients, but she will be logging in as soon as possible for her. Today, I want to extend my heartfelt thanks to my co-conveners, respected Dr. Sneha Boyar, madam. Madam is chairperson of Medical Disorders Committee, Dr. Chaitanya Shembekar, sir, Pranjal Sharma, madam, and my president and secretary, Dr. Suyoga Panat, and Anita Bobde, and my most helping convener and master of ceremony of today's program, Dr. Rajashree Sengupta. I'm thankful to all of you, and I would like to hand over the mic and to Dr. Rajashree Sengupta for further proceedings. Over to you, Rajashree.
Thank you so much, Rashmi ma'am. A very good evening and a very warm welcome to you all on today's webinar. As Dr. Rashmi ma'am has already said, this is a very important series and we are drawing to the conclusion. Today, we are handling the fifth session of this series of Code Blue PPH. We started with the overview first, then we went to the surgical management, After that, we dealt with the medico-legal aspects, and then going through imaging and intervention. Today, we are going to tackle the nuances about blood transfusion and blood components transfusion in the management of PPH. We have two very eminent speakers today and an absolutely fantastic two chairpersons as well to give their expert comments and inputs, valuable inputs into the sessions today. So without much delay, I'll start the session. I invite Honorable Chairperson for the first session, Dr. Sneha Buyar ma'am. Ma'am actually needs no introduction. She is a stalwart. She has been past Foxy chairperson of the breast committee, just finished her tenure, and is at present the ICOG governing council member. She is an extremely affable and a very good academician, known for her sweet smile and charismatic presence always. Her CV, as you know, is extremely illustrious, and it's already posted right over here. Ma'am, I welcome you to be the chairperson for this first session. And our first speaker for today is Dr. Aniket Kakade. He is a consultant and fellow in high-risk pregnancy and critical care obstetrics, and is serving as a professor in obstetrics and gynecology at Bharati Vidyapeeth, Pune. He also has been an extremely illustrious career in high-risk obstetrics and is supposed to have a great command on any topic related to critical care obstetrics. Today, sir will be delivering his first talk on fluid therapy in PPH. I welcome you, sir.
Yeah, thanks a ton, ma'am.
Yeah, before that, I would just like to open the session and welcome Dr. Aniket Kakade. Thank you, Dr. Rashmi, for having us here. And thanks, Dr. Rajasi, for the kind introduction. In fact, I would say, yes, critical care in obstetrics, the much needed care and the upcoming topic of discussion. Definitely the HDU and obstetric ICU, these are the ones, even the government of India and Manyata and various accreditation, they are also asking for it whenever care should be available and the necessary facilities and the team should be there as a part of every obstetric hospital. That is the need of the hour today. And of course, Dr. Aniket is going to throw light on this subject. But just to say that, on obstetric hemorrhage being one of the major leading direct causes of maternal mortality, and when the patient is bleeding a lot, on one hand, you have fluid deficit, and on the other hand, you have a fear of overload. Definitely, definite guidelines and protocols are needed. And for this, may I invite you, Dr. Aniket, for your talk. So over to you. We would like to hear from you.
Yeah, thanks, sir. Okay. Good afternoon and good evening to all. And it's a great honor to be a part of the fifth session of this PPH. And I will be speaking today on the fluids in PPH and how can we go about with these fluids. So infusion of fluids is the cornerstone of therapy in a critically ill pregnant woman. Today we restrict ourselves to PPH, and to understand that we require to know about fluid dynamics. So a couple of slides on fluid dynamics, and then we move on to the fluids. So you have to all know about this body fluid composition, which is all very well known, right from our days of physiology to basic ops and these fluid compartments. As you all know, there is going to be a total body water. Intracellular fluids are going to be 2/3. That are going to be the fluids in the cells. And what we are going to be of important today is the extracellular fluids, in which the interstitial space is going to be having 3/4 of the fluids, and plasma fluid, that is the intravascular volume. So once we are saying PPH and the woman is bleeding, she is going to bleed from this extracellular fluid or the plasma fluid, also called as hypovolemic shock. And when this shock occurs, you require to know that there is a lower line, if you can see, it's the capillary endothelium. So fluid moves from the interstitial space to the intravascular space. Therefore, some amount of PPH can be tolerated. And if this is not corrected, by giving fluids, we will go to crystalloids, colloids, and blood and components. Then the patient goes into irreversible shock and ahead. Total body water is going to be 60% of the weight. There is going to be a sodium balance. Water can cross freely through all compartments, and osmolarities are going to be same within all compartments. So if you add water to all compartment, it goes 2/3 in the total body water. Out of the 1/3, it will go in the interstitial fluid, and then only 1/4 of the extracellular fluid is going to be the plasma, or that is what is going to be important for today. If we give any woman any crystalloid, only 1/4 of the volume is going to be there in the intravascular space, needs to be understood for the day. In maternal adaptations, the extracellular fluid increases by 6 to 8 liters in any pregnant woman, plasma volume by 50%, and plasma volume is increased more in multiple pregnancy. It is reduced in hypertensive disorders of pregnancy, FGR, oligohydramnios, PPRM, and low birth weight babies. We require to know that in hypertensive disorders, more often in preeclampsia, the plasma volume is low. We call it as hemoconcentration, or a very high, a concentrated intravascular volume. But importantly, the extracellular fluid is unchanged. So what happens in patients of preeclampsia is, though there is hemoconcentration, though there is less intravascular fluid, the extracellular fluid is same. That is the reason for this capillary wall permeability. That is the reason why these patients are going to be having edema. That is the reason why if these patients have very bad preeclampsia, there's going to be fluid in the abdominal cavity, ascites, and pleural effusion, and many complications are going to be with this papillary permeability. So that requires to be understood that in preeclampsia, though the plasma volume is low, the extracellular fluid is going to be unchanged. There's going to be physiologic hemodilution in pregnancy, relative anemia, reduced blood viscosity. It benefits the venous perfusion. And the hemorrhagic shock, what happens in this hemorrhagic shock is the plasma volume is reduced. So once we say PPH, we should think of hemorrhagic shock. Once we think of hemorrhagic shock, we should think of the plasma volume being reduced. And what happens with this reduced is, there's going to be a shift of the fluid from the intracellular fluid, which is going to be shifting from the interstitial space into the plasma volume. So what happens with this is, if you correct it, it's going to be well for the woman. If we don't correct it, it goes on leading to fall in hematocrit, fall in hemoglobin, the oxygen capacity is reduced, the oxygen depth increases, and we land up in problem. There is going to be reduced sensitivity to angiotensin 2 in pregnancy, the reticuloendothelial, the renin-angiotensin-aldosterone system is activated and blunted. And with all this, the pregnant woman is prepared to withstand 1 to 2 liters of fluid before signs of moderate shock are there. But then it differs from woman to woman. It's not a rule of thumb. But as such, all the maternal adaptations of pregnancy are so made that the woman is prepared to withstand blood loss. How much? Almost 1 to 2 liters, but for moderate shock. Mild shock has got a different entity. And coupled with this unreliable visual assessment of blood loss, it's a problem. And an important potential confounder is the recognizing this hypovolemia. So if we see patients, we will have a discussion on one patient. So for this patient, if you misjudge the hypovolemia, then you'll end up in problem. And that is the reason why we say there is no rule of thumb for this preparation of loss. And importantly, objective clinical observation and constant reassessment. So once we are doing management of these patients of PPH, we just cannot go on with the management. We require to have a reassessment. Whether she has responded to our management, do we need escalation of care? Do we need referral? Do we need to change the fluid from crystalloids to colloids to blood components? And the talk today will help prevent any delayed or inadequate resuscitation in these women. Shock, as we all know, is reduced tissue oxygenation resulting from poor perfusion. The purpose of circulation is to provide oxygenation and oxidative substrate. And the local tissue hypoxia, not corrected, will lead to organ dysfunction. It will lead to multiple organ failure. If not corrected, patient goes into irreversible shock, and ultimately we have a maternal mortality. That is what we don't want. PPH further exacerbates this atony by causing a mechanical barrier. So once we are doing this fluid management and colloid management and blood management, no doubt we have to achieve a source control. The word that is used many times in critical care is to achieve a source control. So we have to manage the PPH also while we are still managing the fluids. And it all revolves around identification of this hypovolemic shock. And this becomes an important slide to understand what can be done. So if you go line by line, severity, blood loss, volume deficit, and signs. So no signs are seen, and because the woman is adapted to have a loss of at least 1 liter where there are no signs and symptoms, and mechanisms like the cellular shift, capillary permeability, and then the fluid shifts from the extracellular space to the intracellular space and into it. So vice versa, the plasma volume is maintained by all these mechanisms, and the woman then shows mild signs and symptoms with 20 to 25% blood loss, which volume should be 1200 to 1500 ml. She gets tachycardia, but it less than 100 beats, mild hypotension, and peripheral vasoconstriction, so cold clammy extremities can be seen. Moderate shock is when 30 to 35% blood loss, fluid loss to 2 liters, tachycardia comes into picture. She gets hypotension, restlessness, and oliguria. Severe is something when she has lost huge amount of blood. Fine, more than 35-40%, tachycardia, hypotension, anuria is important. So this becomes an important slide to manage these fluid deficits. You require to know how much is the loss, and many complications or many lack of judgment occurs when we misjudge this loss. This occurs more commonly in abruptions, or also when there is going to be an uterine rupture or intraperitoneal fluid, because if we see blood through the vagina and PPH, we tend to act on it. But many times we misjudge the loss which is not seen. And that is the common cause of getting complications, or when we say the patient is not responding to our management, that is because we have missed this severity. So this becomes an important slide to be remembered for long. And then we come to, suppose the patient is bleeding, that means she is losing intravascular fluid, she is having hypovolemia. So how should we assess it? So first and foremost, pulse rate. If you can see the signs and symptoms, pulse rate is going to be there in each and every degree of shock. Blood pressure, hypotension occurs when she loses more than 25 to 30% of fluid. Peripheral circulation, the cold clammy extremities come into picture. Urine output is important. So if you once you are dealing with patients of PPH, it is prudent to insert a Foley's catheter to get an idea about this urine output. It becomes a surrogate marker of the intravascular volume. CVP line, if it is there, it becomes important. Hematocrit falls, that is again important. 2D echo is used in ICU, in intensive. Suppose we are having a patient who has lost blood and we are shifting it to ICU, and we want to know whether there is an adequate amount of fluid intravascularly. The intensivist takes a 2D echo machine, puts on the IVC, infravena cava, and look at its pulsatility and the filling of the IVC. But that becomes a different ball game in the ICU, or direct estimation of blood loss, wherein we can see, because it's going to be PPH, it's a patient is going to bleed, and then we can have a correct direct estimation. And all this estimation reflects in the signs and symptoms. So understandably, estimation of hypovolemia and percentage of loss of fluid is an important marker before we go to the fluids. Fine. As Hippocrates has said, it's a banned sign in acute illness when the extremities become cold, because then the loss is 20% or more. And the human circulatory system operates with a small volume and a volume responsive stroke pump. It is an energy efficient design that limits the workload of the heart, but the system quickly falters when volume is removed. Most organs like lungs, liver, kidneys can lose 75% of their function. We get people who have got only single kidney, people donate kidney. Even that one kidney damage, it still goes on. Liver, 25% of liver is still okay, 50% or less than lung also is okay. But 40% of volume loss in a woman who is bleeding, it goes into irreversible shock if you don't correct. So blood volume, even 35 to 40% is fatal as compared to other organ. And that is the crux of today. The intolerance of the circulatory system to loss of body volume is a dominant concern in any bleeding patient. And time, as we say, is the enemy of a bleeding patient. And that is why we require to be on our toes. So this intravascular volume replacement comes into picture. We are going to restrict to fluids. Fluids means it mostly crystalloids, will come to it. So they are going to be useful in mild to moderate shock. As the patient goes into a massive amount of shock or a severe amount of shock, she requires blood components along with fluids. But with crystalloids, you can manage mild shock. But whereas if the patient goes to moderate shock, then you may add a colloid, or she has to be receiving blood components if you don't want her to go into irreversible shock. So today's talk, fluids. Prompt restoration of the intravascular volume is critical for success, and recommendations of fluids in the critically ill pregnant woman are extrapolated from non-pregnant population. So all the studies, all the books that wherever we see, so all the data about giving fluids in pregnant women are the studies done in non-pregnant population that requires to be understood. There are no studies which say directly 1:1 relation to pregnant woman and the fluids. And PPH leads to depletion of the intravascular volume with shift of fluids. And this shift of fluid from the extracellular space into the intravascular space is going to give rise to hemodilution and fall in the HB. So we require to understand this, that volume to volume replacement. Suppose any woman, any person gives blood donation, the HB doesn't fall. So what happens in hypovolemic shock is the shift of fluids, shift from interstitial space to the intravascular space gives rise to hemodilution, and that is what we are trying to do or achieve by getting a hematocrit or hemoglobin estimation. So the goal of filtration is to support oxygen delivery. Everything revolves around oxygen delivery, and if you see this formula, that the delivery equation has going to be having that the delivery of oxygen to tissues depends upon cardiac output, hemoglobin, and the SpO2. And acute blood loss affects two components of this equation, the cardiac output and hemoglobin. Therefore, the immediate goal of resuscitation is to promote cardiac output and maintain adequate HB. So we should think of maintaining cardiac output if we want to achieve proper oxygen delivery. We should not directly jump to blood or component therapy, because the cardiac output, if maintained, then the body can tolerate anemia very well, and we will come to it as we move ahead in the talk. So the consequences of low cardiac output are far more threatening than the consequences of anemia. So the first priority in a bleeding woman is to support cardiac output, and that is why and when our fluids come into picture. Crystalloids and colloids. Crystalloids are sodium-rich electrolyte solutions that distribute throughout the extracellular space. This is going to be the important line, that they distribute uniformly throughout the extracellular space, and they expand the extracellular volume, and they 25% only remains into the intravascular space after giving them within half hour to 1 hour. Colloids are a different thing, electrolyte solution. They contain large molecules which do not pass through the blood volume. And they were as early as 1861 when Thomas Graham had an investigation which led him to classify substances as crystalloids and colloids depending upon their ability to diffuse through a parchment membrane. Crystalloids pass easily, whereas colloids, they were called as colloids because it was the Greek word for glue, do not pass. So intravenous fluids are also classified as crystalloids and colloids depending upon this capillary wall. So in Thomas Graham's experiment, it was the parchment membrane. And today, once we talk about crystalloids and colloids, it will be the capillary wall. Crystalloids are going to be there, which are going to pass through the capillary wall into the interstitial space, whereas colloids tend to remain in the intravascular space, but they have their own disadvantage that we will be knowing at the end of the talk. Fine, so the preferred fluid, there is no doubt about it. Fine, so it is going to be crystalloids, and it is the first choice fluid since hemorrhagic shock since last 50 years. So it is time tested. So if somebody asks what is the preferred fluid, it has to be crystalloids. And then we can have some situations where there can be colloids, which can be useful. So crystalloids or electrolyte solution, ion concentration can be altered. They can be isotonic or hypotonic, and they equilibrate throughout the extracellular space, do not cause any shift. And they are most commonly employed are the NS that we say, lactated dingers and plasma light, isolite. We will have a short slides on each one of them. So these are the commonly used crystalloids. And what happens with them is they flux across the microvascular wall, and therefore we can predict how they will distribute between the intravascular and interstitial space. This equilibrium between the spaces is achieved within half an hour after infusion. Again, more importantly, only 25% of volume of the infused crystalloids is going to remain in the intravascular space. Therefore, you require to transfuse large amount of crystalloids if you want to make up for the intravascular loss. And in critically ill woman, only 20% can remain there in the circulation. But at least remember 25%. Suppose we give a patient 1 pint of RL, then it is going to be 125 ml of plasma volume, which is going to be effective. That is the way we calculate the loss. That is the way we make up for the loss in intravascular volume. This is going to be, it is there. It is going to be the capillary wall. And if you give any woman a pint of RL, then only 20% of it is going to be effective in the plasma volume, whereas the rest of it is going to be into the interstitial fluid or making it for the interstitial fluid loss. Fine. These are the commonly used fluids: Syngas Lactate, normal saline, plasma light, and albumin and head starch are the colloids. And this is their equation. Sodium, they are all electrolytes, and they diffuse very easily through the capillary membrane, and they are going to go equally into the intravascular and the interstitial space. And because only 20% of fluids are there in the intravascular space, they are going to be causing only 20 to 25% rise in the intravascular volume. And then we come to the commonest use called as normal saline, an osmolality which is going to be as comparable to the fluids, and it has got 0 calories. It's called as normal saline because the percentage of sodium chloride dissolved in solution is similar to the average concentration in the intravascular space. It's isotonic, and it's most commonly, initially it was used for extracellular fluid circulation, but we use it quite commonly for intercellular or intravascular fluid deficits. Then comes Syngas Lactate, devised by Sidney Ringer initially as Ringer's infusion, then added lactate to it, gives right to the name called as Hartmann's solution. Then Ringer's injection was called as Ringer's lactate. So once we say Ringer's lactate, it's nothing but a Hartmann solution. It going to contain lactate. But then again, they don't cause very severe lactic acidosis or chloride concentration. This occurs when they are given in very, very large amount. That is not our concern. We rarely give this much amount of transfusion in obstetrics to cause acidemia with an NS or higher levels of sodium lactate with Ringer's lactate. So what we give is not going to cause any of these complications, and they are extremely safe fluids, but they have to be used judiciously in preeclampsia. But a PPH woman who is bleeding does require these important fluids. Then we come to this new prototype. New means a little bit different. They're called as isolites. And isolite importantly contain dextrose. So they are very good fluids if you want to give the electrolytes along with dextrose. So they are better for post-op management. And what we use commonly is isolite E, which is going to be an important fluid giving dextrose and the other types of electrolytes. And isolite E is going to be commonly used. Multiple trade names are there. There is a Cabilite, and multiple companies do come into picture. They cost a little bit costlier than this. Fine, Ringer's normal saline, as we all know, cost between 10 rupees, 20, 30 rupees, whereas isolates cost 130, 140, and the costliest are the colloids. So colloids are large molecular weight substances where the cell membranes are relatively impermeable. They increase the oncotic pressure. They remain in the intravascular space. They prolong the duration of action. Net result is that lower volumes are needed. So if you want to increase the intravascular space, if you give colloid, it will give rise to 1:1 increase in the intravascular space. If you give 1 pint of RL, it is going to increase by only 125 ml. So that is the difference between crystalloids and colloids and their intravascular thing. Upper three are dextrose, normal saline, and Ringer's lactate. 5% dextrose doesn't have any role in fluid excretion anywhere. So you can as well as remove that thing from your shelves. And what we require to know in colloids is hemacil, gel fusion, and heat starch. Albumin also doesn't have direct role in any management of PPH. Albumin in ICUs are a different thing. So we restrict today to hemacil, gelfusin, or volulite. Fine. So hemacil, active substance, it's going to be infused intravenously. It's going to contain polygelin. It costs 500, 600 rupees, not used widely nowadays. Fine. It has got significant amount of anaphylactic reaction, disturbances of the coagulation system. Therefore, it was initially, 5 years down the lane, hemacil was pretty evident. So each and every OT, each and every ICU or obstetric nursing home was bound to have hemacil. But nowadays, we are having better alternative. And instead of having hemacil, it is better to have volulite. We'll come to it in the next slide. Other drug was, or colloid was gelfusin. It's again succinated gelatin, 4% intravenous solution. It is again going to be there, little bit costly. And what is more important is this, which I think is the better one, is the volulite. Fine? And voluven is something which only contains hydroxyethyl starch. Initially, it was voluven in 2 or 3 nursing homes last month or so. We talk about this voluven. So instead of having voluven, it is better to have volulite. So what happens with volulite is it contains hydroxyethyl starch 132.4 in a balanced crystalloid solution. So it contains starch. It also contains crystalloids. So it becomes a better solution. Only thing is costly. But 713 rupees cost is not much once we are dealing with this PPH and management. So something which is better to be have in OT will be volulite. So this is just from what experience we are having in our HDU, ICUs, and other anesthesiologists and intensivists in Bharati. that we are replacing volulite. So instead of using Voluven, instead of using gelfusin, instead of using Hitastarch, if we have a colloid in our OTs, it is going to be volulite. It's a colloid balanced crystalloid solution, but very useful. And this is the content of volulite. So it's a pretty sensible thing. So it is pretty balanced solution, should be used widely, right? And then Hitastarch comes, and Hitastarch, Hexastarch, Pentastarch, and they cause disturbances only in large volume. So that is not our concern. A bleeding PPH woman, life is more important than these minor coagulopathies and lactate acidemia and everything. You can very well transfuse a couple of these things, and we'll come to know how much and into it. And then we come to this classification again. So class 1, class 2, you can manage with crystalloids. As if you give class 1, class 3, you require to add colloids, and class 3 and class 4, you have to go with blood and components. So the role crystalloids has is till the arrival of blood. So you can wait for time till blood comes. Till the time you should manage this patient's first choice crystalloids. If there is no blood coming, then you can add a colloid, and then blood is going to be the unique. Nothing matches blood when we come to intravascular volume resuscitation, but in class 3 and class 4. So there is no sense in giving PCV for a patient who is having class 1, class 2 hemorrhage. But there makes huge sense in giving PCV and FFP and platelet, of course, in class 3 and class 4. So my concern is again to know that which class this patient is. Therefore, you require to know the signs and symptoms of intravascular loss and the percentage of loss. If you know the loss, then you can correct with crystalloids, colloids, and blood. So instead of giving something ready-made, if you know how it works, then it will help. And how much amount is what we are concerned. So if you give crystalloid in this slide, this is going to be the plasma volume. Fine, this is going to be the vascular compartment. Most of the crystalloids is going to go into the interstitial volume. 25% is going to be there in the plasma volume. Whereas if you give colloid, a huge chunk is going to be there in the plasma volume, and very less goes into the extravascular compartment. But the issue with colloids is if you transfuse them in a high quantity, it can cause some problems in the blood coagulation system. Therefore, we don't use them right, left, center. A judicious advice is to give crystalloids initially. If there is time for blood or components, or you require to shift the patient, then you can give 1 unit or maybe 2 units of colloid, but don't use it as an alternative to blood. There is no alternative to blood and blood components. Crystalloids and colloids are going to maintain the cardiac output. And in the absence of severe anemia, it is going to be important. So if you maintain cardiac output, many things are prevented. And once you get this irreversible shock, this is when we give only crystalloids and colloids, and we don't go give any blood. That time the patient goes into irreversible shock and problems arise. So this is the volumetric effect. If 1 liter of volume of normal saline is given, then out of that interstitial volume is going to be 25, whereas the plasma volume is going to be only 275 to 300. Whereas whole blood, it all remains into the intravascular volume. So nothing matches whole blood, but then you require to know whether it is class 1, class 2, class 3 or class 4 of hypovolemia. Fine. When we are doing all this, the anesthesiologists and intensivists use their own formulas for calculating the volume deficit and resuscitation. But what we require to know is if you are having a loss of 1 liter, then you require to give colloids in 1:1. And if you are giving crystalloids, you require to give 3 times more. So if you want to make it for 1 liter loss, then you may require to give 3 liters of crystalloids. So that becomes a concern. So you can give 1 colloid and crystalloid and then come to PCV transfusion. That is the way it goes. So this is done by the intensivists and anesthesiologists into it. And then we come to monitoring. So once we are giving this fluid, you require to know that we require to do continuous assessment of urine output. So if the patient is receiving resuscitation and PPH, it is prudent to insert a Foley's catheter. Look at the mental status, heart rate, blood pressure, respiratory rate, blood pressure by giving an arterial line if at all, temperature, and serial measurement of electrolytes, hematocrit, platelet, PT, APTT, and INR. Because if we go on giving fluids, there's a fair chance of patient having any dilutional coagulopathy, which is what we don't want. And more intensive monitoring is required if the patient doesn't respond. Then she becomes a candidate for ICU management. And what are the endpoints? Because we are giving fluids into a good amount. So what can be the endpoints of resuscitation? So cardiac output. We require to promote cardiac output. So a MAP of 65, a urine output of more than 0.5 ml per kg per hour, HB of 7 to 9 is prudent. Fine. We need not go to have an HB of 10, 11 in a patient who is bleeding. 7 to 8 is good enough, SpO2 of more than 90, and lactate of less than 2. Lactate is an important thing. It comes on ABG. We require to maintain an INR less than 1.1 and a APTT of less than 1.5, the control. Fine. So if a patient is going to bleed, and if you give saline, the hematocrit falls. Whereas if you give blood, it doesn't cause any problem in the hematocrit. This requires to be understood once we do this discussion. Then we come to this word called as fluid challenge. We are having a patient who had PPH, suppose on table, but only class 1, class 2, and she is in the recovery room, and then the output is less, and the resident says, thoda RL bada dete hai, thoda fluid ka jada deti ho. So what jada means, if you want to give a fluid challenge, so the challenge is 500 ml of saline over 15 minutes. That is the ideal challenge to know whether the patient is responding to increase in intravascular volume. So what we give is very marginal. It is not at all a fluid challenge. It's again what we give to just transfuse some amount of fluid, output aa jate hain, and then we are happy. So if we want to give a challenge, that challenge is that much huge. So the challenge that is given in the EMD or the ICU or the anesthesiologist is over 15 minutes. And if it doesn't cause any increase, then the patient doesn't have any intravascular loss. She may be having a different type of shock, a cardiogenic shock, or a different type of shock like neurogenic shock. So if the urine output increases with fluid challenge, that means she has got deficit in the intravascular volume. Passive leg raising is a built-in fluid challenge. So once you are doing all this management, it is prudent to have a leg raising. It is prudent if you have got a pneumatic anti-shock garment, it is prudent to apply it before you shift the patient, because they will cause a fluid shift and maintain the intravascular volume. Then we come to important is what vascular access to have. So the best vascular access is the 18 gauge line. Fine. Initially, it was thought that we should have a huge line like a CVP line where we can transfuse much amount of fluids. But by the Hagen-Poiseuille equation, a 18 gauge line, peripheral line, is the best to give lots of fluids. So if you are planning massive transfusion, have two 18 gauge lines. Don't think of having a CVP line, because the CVP line has got a length. It's 8 inch, whereas the intracath is 1.2 inch. And that is what is required. If you want to transfuse massive fluids, have a wide bore short catheter in any good vein. It can be the peripheral vein, cubital vein, external jugular. You did not go for a CVP line to cause massive transfusion. CVP line is not at all used for any massive transfusion. It has got a different role altogether. So for PPH, peripheral line, only thing is 18 gauge. A big good line is important. Serum lactate is a wonderful thing to be used for assessing resuscitation. So if our goals are achieved, lactate of less than 2 is the best. So if you want to assess whether you have done a good resuscitation, it's good to have a ABG and see the lactate levels. If they are less than 2, then you have done a good job. Blood volume and RBCs. There is a concept of hypovolemic shock, but there is no concept of anemic shock. Please understand that. We have seen patients like ectopic who have HB of 2. They don't do anything. They do well. You do the ectopic surgery, transfuse, they become well. We have seen gynec patients who are having HB of 2, 3 doing well. But if a patient of PPH loses blood, her HB comes to 2, 3, and we make an error in the fluid management, she goes into irreversible shock and then she doesn't come out. So no, there is a concept of hypovolemic shock, but there is no concept of anemic shock. Red Cross change in this, blood saves life. A better thing will be blood volume saves life. So maintenance of volume. So before you think of anything, maintain the intravascular volume, correct fluids, correct dose, and proper shift from crystalloids to blood is going to be the thing. So blood volume is what is going to save life. We will have one case discussion. It will take few minutes if all are okay with it. This is what we managed last week itself. Fine, a few slides if all agree. Fine. So patient was referred 40 kilometers from the city of Pune, wherein a cesarean section was done, and the patient she was a second gravida. Previous LACS was the indication for the section, and on table she bled. But then the parameters were okay. They did cautery, they gave prostadine, closed the abdomen, and the patient started bleeding, atonic PPH in the recovery room itself. And then it went down bleeding. They gave crystalloids, they gave some 2 hemacils, but the patient, they had a significant amount of bleeding. They called a senior professor in our unit, and then the team was kept ready, and they thought of shifting the patient from 40 kilometers to the Bharti hospital. Patient was received in the EMD and resuscitated, and then there was a pack kept, and once the pack was removed, there was all blood. So significant amount of PPH was there, and then this patient now required a source control. So we have to do management of fluids as well as we have to achieve a source control, because otherwise there will not be a proper management. So the anesthesia team came there, they managed her. The pulse was surprisingly 90, BP 50/40. Put on 8 ml of norate, respiratory rate was 30/40, and severe PPH was there. The output was nil. There was a Foley's catheter from the LSCS done. The output was nil. Patient was conscious but not oriented, and the CVS was muffled sound, and a significant amount of blood loss was there. The ASA given was 4E, death on table, consent taken for obstetric hysterectomy. The patient went from EMD to OT. Fine. Otherwise, if you get a properly managed PPH, then the patient goes from EMD to ICU because of a source control being done. But here the patient was still bleeding, so we required to achieve a source control. Therefore, the patient was shifted to OT. ABG gave a HB of 2 to 3. So very less HB, and GA was given. So this patient came into this. So maybe she was having a blood loss of 2, 2.5 or more, because she was having hypotension, restlessness, oliguria, and altered consciousness. And this is the intensive monitoring chart in the OT. So in the OT, access was there by 18 gauge French line. Fine. On the line, there was a 20 gauge line from the referring consultant, but we required to put 2 18 gauge. Okay. One was put in the external jugular. And then this is the crystalloids. Fine. She received 4 units, RL2. This was isolate E, and the fourth was RL. And then she was given blood, because this patient required crystalloids till the management of the intravascular volume. And then blood has to be there because she was class 3, class 4 shock. So 3 PCVs, 4 FFPs, 4 RDPs, massive transfusion protocol was activated. So 4 units were cross match, 2 were O negative, and then we got a cross match blood for her. And the ECG was showing a normal rhythm. And then the total blood loss, this is again a rough estimate. Fine, because we cannot estimate what had occurred in the referring institute. So in our OT, we had an estimate of suppose 2000 liter. There was a massive PPH. So, we opened the abdomen, the incision was again open. It was for totally atonic. And with this HB of 2 and very high lactate, the only option was an obstetric hysterectomy. So an obstetric hysterectomy was performed. The blood loss was 2 liters, and crystalloids were given 2 liters. So only 25 will be there in circulation, we say 500. And colloids and bloods managed with the other thing. So we required to give 1:1 transfusion of these colloids and of blood and FFP and RDPs to make up. And then the urine output gradually improved. Patient was then shifted to ICU, 2 days in the ICU, taking care of these things. HB improved and coming. This is about the lactate. This is the OT lactate. So the lactate is showing 6.2. So once she was referred to us, she was referred by giving crystalloids, and they had given 2 hemacils, but no blood. And because of this improper, not optimal, because getting blood also in the periphery becomes a challenge. So they had no option. It was better that she referred us because we could salvage this patient. So the lactate is 6.2. And then in the OT, after giving all this blood, it came to 3.9. Next day, with all these management of proper crystallose and colloids, the lactate was 1. So we suggest that it was an optimally managed fluid thing. And this is the documentation. A huge amount of team is required for this cases management. This is documentation of each and every PCV, each and every FFP, each and every bag number, date of issue, date of collection. It requires a huge team for this 9 things. So the take-home message is treat the cause of PPH once you are doing this fluid excretion. So source control has to be there. In the ICU, we have got friends who always ask us, is the source control? So a patient who is properly managed from EMD, she goes to ICU. So we correct DIC. But where there is still bleeding, she requires OT. Understand fluid dynamics, a competent team at the head end. What happens, we are blessed in Bharti, we don't have to think about the head end. Suppose we are having a patient of placenta, accreta, increta, and we just stick to the layers, tissue, PPH control, and the blood and the hemostasis, whereas the team takes care of the fluids. We don't have to think whether she is giving RL or isolate. Blood automatically comes, FFP automatically comes, they transfuse, and they manage everything. So this competent team is there. Go for oxygenation. So once you are giving fluids, giving oxygen through the nasal prongs is important. Wide bore peripheral access, crystalloids with vasopressors are the choice. You have to look at the logistics of skilled manpower, blood products, and what equipments you have at your end. There is a concept of hypovolemic shock where there is no concept of anemic shock, and dilutional coagulopathy requires to be looked into. So not only different types of fluids we have at hand, but the precise use of fluid in the situation matters. ABG and the role of lactates are there. Time is the enemy of a bleeding patient. So we require to know when to escalate the care, when to go from oxytocin to balloon tamponade, from balloon tamponade to hemostatic suture. From that to shifting, from shifting to escalation to an internal ligation or OH. So this escalation is important, and reassessment of endpoints, whether the fluids have acted, whether the colloids have acted, whether the blood has acted. So we require to reassess. We just can't be lenient with the bleeding patient. And counseling and documentation is a huge thing which requires to be known. And a big thank you to Rashmika ma'am for the opportunity. Fine. Reading and interacting with our good anesthesiologists, Dr. Abhay Sancheti and Dr. Varshali Kenia, also made me aware about these minor nuances about these Isolites and colloids. And Dr. Prashant Jedge for his inputs with respect to management of PPH in the intensive care. And life becomes easier when you have the right people on your side. A big thank you to all of you and for giving your time this evening. Thanks, Satan.
It's a wonderful talk. I think you can stop share, Dr. Aniket. Wonderful talk. I'm sure all the obstetricians are benefited from this. And yes, definitely you have given a very good message. I think right from the beginning as an obstetrician, recognition of postpartum hemorrhage, the moment you see that there is little extra than what we usually see, that is the first point you have to, make alarm. And of course, for fluid therapy, you have done full justice. It's not only replenishment of the volume, but maintenance of hematocrit, oxygenation of the tissues, the osmosis, the coagulation, and the electrolytes. So everything has to be taken care of. It's not only the volume, you have to manage not to not to overload at the same time, not to give lesser fluid. So you have to be very, very meticulous as far as the monitoring is concerned. And yes, you have to achieve the optimum goals, what you have already said. At least we have to see that the blood pressure is maintained at 90. Every hourly she's getting the urine output of 30. And you have to maintain the hematocrit also. But yes, if it is mild, fluid therapy is going to help. But as you have rightly pointed out, fluids only till you get the blood and the proper blood and blood components. Of course, recognition the source of bleeding, stopping the source of bleeding, and continuation of the fluids and then the blood, and the definitive management of the postpartum hemorrhage. That should, make you successful in treating this PPH. Such a severe PPH you have managed so well. Of course, we have been saying, call for help and a multidisciplinary approach, what you are blessed with the team. So hearty congratulations to you for managing the patient and the wonderful talk. Thank you so much, organizers, for having me here. Thank you, dear Rashmi.
Thank you, dear Sneha ma'am. Dr. Aniket sir, I should inform you that was a top par excellence, and you had a viewership of, I think, 438 viewers for your talk. And you could go to the comments on our group and you would come to know how impressed people were with your talk. It was really a very informative talk. You have covered everything. I would like to extend a very warm welcome to respected Dr. Harish Varbe sir. He has joined, and Dr. Alka Kuthe madam. Welcome, ma'am. I think Dr. Sujata Darbi madam, Secretary AMOGS, had also joined. I think she was busy and she has left earlier. Dr. Aniket sir, you have covered everything, but I have some 2-3 questions from the audience. Yeah. And if you permit. I know. A question is that the obstetrician and gynecologist is very much concerned at a point when patient develops oliguria or anuria when she's in shock. So at this level, how much percentage of volume deficit must have occurred in the patient? I think you have covered.
With oliguria, it goes to moderate to severe amount of shock. So we are going to be having a deficit of 20 to 30% of things. So, we need not worry about this urine output. You can very well transfuse a good amount of crystalloids. 1 to 2 liters can be safely given because only 25% remains in circulation. Until the time blood arrives, that is going to be the thing. So maintenance of intravascular volume and cardiac output is the crux. So need not worry about urine output at the time of initiation. You require to be worried about your output once you reassess your goals. Has the output improved or not improved? So with no output, she requires fluids.
Thank you, sir. There is one more question. And somebody has asked about what is the rule of 30.
Rule of 30 means, it was, think of, if the baseline pulse increases by 30, if the systolic volume reduces by 30, or, if the patient gets respirated, which is going to be more than 30, then that is again suggestive that there may be 30% or more loss of fluid. But that is again called as the rule of 30. Better is to not to stick to only one parameter. Look at 4 or 5 parameters of intravascular volume and try to putting it in that for first, class 1, class 2, class 3, class 4. Getting that in percentage is more important. Rule of 30 is a mnemonic to remember, but better to remember the whole chart which I posted.
Thank you very much, sir. You can really appreciate the white smiles on mine and Rajesh's face. We have read all the compliments and comments on the group.
Thank you for the effort and
was
for
really
the opportunity.
Thanks.
Thanks.
Thank you very much. Over to you, Rajesh.
Thank you so much. After the first wonderful talk, I am actually carrying forward a line of Sir's talk saying that time is the biggest enemy of a bleeding patient. And before we lose time, we have to get her blood and blood component products. So to elaborate about that, we have our second talk on blood transfusion protocols in PPH and the rationale behind using of blood transfusion and its components by none other than Dr. Harish Varbe, who is the Medical Director of Lifeline Blood Bank at Nagpur. And to chair the talk, may I invite Dr. Alka Kuthe ma'am from Amravati. She has been the National Coordinator of the FOXI Ethics and Medico-Legal Committee and past President of Indian Medico-Legal and Ethics Association. She has also been a founder member and National Secretary of the Human Milk Banks Association of India. She has a massive knowledge and a strong hold on medico-legal aspects and ethics committees in various fields of OBGY. And she has always startled us with her massive knowledge in all the CMEs and conferences. Also, she's a very gentle and soft-spoken teacher herself. I welcome you, ma'am, to chair this session and also to give a formal introduction of our speaker, Dr. Harish Varbe, sir. Welcome, ma'am.
Yes, thank you, Dr. Rajeshri, for a nice introduction. At the outset, let me thank AMOGS, all the concerned committees, President Dr. Rajendra Pardesi, sir, Secretary David Madam, especially our Dr. Rashmi Kahar, and our own OBGY Society, and of course, Dr. Sneha, for inviting me for this wonderful and important webinar. Actually speaking, PPH, postpartum hemorrhage, is nightmare for all obstetricians. We know how to deal with the patient, but practically speaking, there are many practical difficulties and medically we need to be safe in the current era of consumerism. So in those circumstances, the speaker or faculty like Dr. Harish Varbe sir would be the most appropriate person to introduce us, because many times what we find, we face shortage of blood. And many times it is not indicated at all. So actually it's a misuse of blood. So we need blood components, but we don't know when to use blood and when to use blood components. To guide us on this very important issue, PPH management protocol and the role of components and blood as a whole during management of PPH, we have Dr. Harish Varbe sir amongst us. Kindly display the CV. Rajeshri, can you display the CV of Dr. sir?
Yes.
Yes. Vasisht will display. He will display.
Yeah, I can go. Actually, Dr. Harish Varbe sir needs no introduction. We know his tremendous work during COVID area. Even I have witnessed that when my brother-in-law was admitted in COVID pandemic, and there was a lot of work assistance given by Dr. Harish sir. He's a medical director of Lifeline Blood Center Nagpur. Especially he's for stem cell component therapy is known for that. His hospital is NABH accredited as well as international accreditation. He has received international accreditation for the advancement of blood and biotherapies. And this was formerly known as American Association of Blood Banks. He has got many professional positions. He is NABH Assessor, Quality Council of India, Government of India since 2015. He is expert committee member, State Blood Transfusion Council, Government of Maharashtra. Expert committee member of AATM, this is Association of Asian Association of Transfusion Medicine. He is president of Federation of Nagpur Blood Banks. He has received many awards and honors to his credit, awarded by Government of Maharashtra, the largest blood center in Maharashtra state. He has received Lokman Times Healthcare Excellence Award in May 2022. That is the tremendous work done by him during COVID pandemic. Next, please. And about his, he has received that Arogya Ratna Award at the hands of Honorable Sri Dayashankar Tiwari, Mayor Nagpur Municipal Corporation. He has received COVID Yodha Puraskar at the hands of Honorable Sri Nitin Gadkari Ji, Union Minister of Government of India. He has received Corona Warrior Award at National Conference of Indian Society of Blood Transfusion and Hematology. Again, about many charitable activities. One is famous, one is popular for doing some work for his colleagues, patients. But there are many charitable activities to his credit. He has
Rajyasree, are you able to listen?
Yes. No, I think her she's frozen.
Okay. I think the bandwidth might be low. Let's wait for it.
Concessional blood supply to cancer patients. It is regular activity by him. He has offered concessional blood supply to poor senior citizens, delivery patient or ANC patient and children. He has given free blood supply to government hospital like GMC, IGMC, because we know government hospitals are there, but we have shortage of blood because everybody referral center is government hospital is a referral center, so it's like a tertiary care center. So much shortage of blood. But if some person like Dr. Harish Varma is there, we get so much assistance to help our DD patients. So this is about his CV. So I will request Dr. Harish sir to start his lecture.
Thank you, madam, for your kind words of introduction. Shall I start the screen share?
Yes. Yes.
Yes. I think it is visible and I'm audible also.
Yes, sir, you are audible.
At the outset, I must thank the AMOGS, their office bearers, specifically Dr. Rashmi, for inviting me to talk on this very important topic of blood transfusion protocols in PPH and the rationale behind the transfusion of blood and its components, which is a very near and dear topic to my heart.
Can we make it full screen, sir?
I think it is full screen already. Is it not?
You have to make it slideshow.
Slideshow.
Topmost.
Is it full screen or not?
Not yet, sir.
No, sir, you will have to go through.
Now
Sir, you will have to go through slideshow. Slideshow and
Where?
from beginning.
From beginning. Okay. Now it is okay.
No, sir, not yet.
I'm afraid, sir, we are still not able to see full screen.
Now you are seeing the half screen, partial screen.
Yes,
Slide-wise we can. Yes, slide-wise we can see.
But if I click on the slideshow, it is now, to me, it is showing the full screen. Whether the slides are changing?
Yes, sir, slides are changing, but we can see it on a smaller screen, sir.
Okay.
Like
Sir,
not
please.
the full screen view.
No, slides are changing, sir. Slides are changing.
Now it is not full. It is not full screen at my end. But now, if I go to these, I think this should be the full screen at chart now.
Ashish, if you are there, can you help us?
Slides are changing, only this not the screen.
I will again stop and start again.
Yes,
Okay.
that you can.
Yes.
Is it okay now?
I think we can continue. I think.
We can continue. Okay, okay, right. Uh, as far as blood transfusion in PPH guidelines and protocols, every hospital is expected to have their local guidelines to treat as far as the blood transfusion is concerned, just not for only emergency or in massive transfusion, but for all the blood transfusion process. If those are not, and that is to be done by the hospital transfusion committee that is to be constituted at every hospital, and depending upon their resources and the circumstances available, they should form their transfusion protocols and for their own hospitals. But if that is not formed, which is the case in majority of the cases, one should follow the national guidelines by National Blood Transfusion Council or State Blood Transfusion Council, or else then one can follow the international guidelines like from WHO, International Society of Blood Transfusion, American Association of Blood Banks, or British Hematological Society, Canadian Blood Services, or Australian Blood Services. Here in today, I am going to give my reference to the WHO module, which has come last year only 2021 on the patient blood management and the clinical use of blood. These are the major causes of obstetric hemorrhages, right from fetal loss in pregnancy, ruptured ectopic pregnancy, APH, traumatic lesions, primary PPH, secondary PPH, and DIC, which I need not go into details. You are the masters in it. And these are the various signs and symptoms of massive hemorrhage. And prompt recognition and management of PPH reduces the number of deaths. And major obstetric hemorrhages may not be present with the clear signs of hypovolemic shock if there is not big loss. Healthy individuals can successfully compensate 20 to 25% of the blood loss without any overt signs of hypovolemia, which is already made clear by Dr. Aniket in the earlier presentation, very nicely and excellently.
The slides are not changing, sir.
Oh my God.
Slides are not changing.
I will again stop sharing.
Previously they were changing, but not full screen, but now the slides are not changing.
Stop share. Am I visible now?
The slides are not visible now, sir. The first introductory slide was projected up till now.
Oh my God. Share. Is it available?
Yes, sir. Now the slides are
Yeah.
the slides are moving now.
Yes, yes. Okay. These are the various causes of major obstetric hemorrhages. Can I continue with this similar this type of presentation? Is this okay, or shall I make it full screen? Try to make it full screen. Is it?
Sir, this is fine, I think.
This is fine, or this is fine. Both are the same.
Yes.
Both are the same. Okay. Signs of hypovolemia in major obstetric hemorrhages, Dr. Kakade has very well demonstrated, shown. And the management of major obstetric hemorrhage, medical management, you are already very well aware of. I will go straight into the protocols for massive transfusion and emergency release of the blood products, the last line. As per WHO guidelines for management of obstetric hemorrhages, there are three main things to do. One is resuscitate, then monitor, and then stop the bleeding. To resuscitate the patient, give high concentration oxygen low position, IV access, crystallized colloids. Then activate if the things, meanwhile, you have to do all this, but then definitely you should plan to activate the massive transfusion protocols and notify the blood bank. Give the ORH negative emergency release of red blood cells until the ABO typing is known. ABO blood group is known of the patient. Once the antibody screen is complete, one can give the fully cross-matched red blood cells when available. And meanwhile, till the time the blood group is not known, you can keep giving the AB plasma, which is a universal donor. O positive, O group is the universal donor as far as the red cell is concerned. For plasma and platelets, AB is the universal donor. Use the pressure infusion device or warming device if possible, and you must call the extra staff once you activate the massive transfusion protocols. Second is the monitor and investigate. Ensure the blood bank has the recurrent sample of cross-matching, because after transfusion of like multiple blood units, the content of the blood inside the patient is going to change, and you should keep sending the fresher sample as far as possible, as and when it is possible. Do the CBC and coagulation test and continue to monitor. Continuously monitor the vitals and capillary refill time. Insert the catheter and monitor the urinary output. And the third is to stop the bleeding. Identify the cause. Examine cervix, vagina for laceration. If there is retained product of conception or uncontrolled bleeding, treat as DIC. If the uterus is hypotonic or atonic, then bladder has to be emptied. Give oxytocin, ergometrine, or oxytocin infusion, bimanual compression, prostaglandin, or if bleeding continues, then tranexamic acid can be given after within 3 hours of the birth. 1 gram IV at 100 mg per ml, 1 ml per minute over 10 minutes. And the second dose of TA can be repeated if the bleeding continues for 30 minutes and if the bleeding restarts within 24 hours of the first dose. And consider surgery as soon as possible if the bleeding doesn't respond. About the DIC, it is the cause for massive obstetric hemorrhage triggered by placental abruption, intrauterine fetal death, eclampsia, or other causes. The clinical picture ranges from major hemorrhage with or without thrombotic complications, or the patient may remain clinically stable, only can be detected by the lab testing. And how to manage the DIC? Treat the cause, either deliver the fetus or placenta, evacuate the uterus, give the uterine stimulants, give the fluids as told by in the previous presentation, and use the blood products. If the patient is massively hemorrhaging, then transfuse the blood product according to massive transfusion protocol. If the blood loss is less severe, transfuse products according to lab values or the clinical signs and symptoms. If the HB is less than 7 gram, then transfuse the packed red blood cells. If the PT-PTT is more than 1.5 INR, then transfuse FFP 10 to 15 ml per kg body weight. If the platelet count is less than 50,000, then give the SDP. If the fibrinogen level is less than 2 gram per liter and the patient is bleeding, you should give the 10 units of cryoprecipitate. If the cryo is not available, then FFP can be given, but this will give a lot of volume overload to the patient. Nowadays, we maintain the cryo inventory very well. And these are the lab tests we have to keep monitoring, like platelet, PT, APTT, thrombin time, fibrinogen, and FTPs. If the lab tests are not available, say in the periphery, then one cannot depend on the lab test to manage your patients. Then the very simple test which can be done in the OT or in the obstetric room is, as per WHO guideline, take to 2 to 3 ml of venous blood in the clean plain test tube. Keep it, hold it into the fist warm at the body temperature. And then after 4 minutes, keep it tilting every minute. It should clot within 4 to 11 minutes. But if it remains fluid beyond 15 to 20 minutes, it's the clear-cut case of DIC, and you should initiate the treatment without waiting for the lab results. If the DIC is suspected, do not delay the treatment waiting for the lab results, and the replacement of blood products must be started as soon as possible. How to initiate the massive transfusion protocol? What should be given? The blood, whole blood, or component? Now, in the era of components, whole blood, it is the kind of old product, and one should try to give the blood component specifically. See what happens with the whole blood when it is stored at 4 degrees centigrade. Once the platelet, the temperature of that particular blood comes below 15 degrees centigrade, the functional activity of the platelets goes down, and the labile clotting factors are stable at minus 30 degrees centigrade. So in case of like whole blood which is stored at 4 degrees centigrade, the only active component remains the red blood cells with inactive plasma and platelets and WBCs, which can give rise to more adverse effects. So whole blood, it is the cocktail of various components of drugs like red cell, WBCs, platelets, and plasma. And every component of blood is associated with the potential hazards like red blood cell can cause the hemolysis, illumination, refractoriness. WBCs can the febrile reaction, TRALI, TAG-VSD, immunomodulation, and the CMV transfusion and refractoriness. Platelets can cause the illumination and the refractoriness. Plasma can cause the allergic reaction, anaphylaxis, TRALI, dyspnea, or febrile reactions. And since the whole blood has the higher volume, can precipitate the cardiac overload also. So with all this consideration, one should ideally give the whole blood, should not give the whole blood, and should try to give the components only. Because whole blood, there is volume overload, more transfusion reaction, and it's a wastage of precious blood. But then there are few relative indications of the whole blood when there is a dual requirement of the oxygen and the volume overload, like in case of exchange transfusion in the babies or massive transfusion. But these are the relative, not the absolute indication. Massive transfusion means when the more than 50% volume replacement occurs in less than 30 minutes, or more than 100% volume replacement occurs is done within 24 hours. Massive bleeding is when blood loss is more than 25%. Massive transfusion, you have to give the red cell, platelet, and plasma in the ratio of 1:1:1 after initial transfusion of 4 units of RBCs. And the rapid transfusion is added when the rate is more than 50 ml per kg per hour, or in case of children, 15 ml per kg per hour. These are various terminologies and should not get confused, interchanged. As far as fresh whole blood, in case of massive transfusion, there are certain conditions and illnesses where we need the fresher blood, but in routine cases, which is not the case. Situations where the fresher RBCs are required are massive transfusion, fresher is the better. Babies up to 3 months, less than 5 days, open heart surgery less than 10 days, and chronic renal and liver failure more than 40 days. Why? With the storage, the potassium content in the blood keeps on increasing, and with the storage, 2-3 dpg level keeps on dropping. If the ATP level drops, then even if you are transfusing the old blood, the oxygen delivery does not happen. See, your hemoglobin concentration may go from 4 to 10, but the oxygen delivery will happen in the evening. So this will give the false sense of kind of blood transfusion adequacy if we give the old transfusion, old aged kind of old pack red cells. So in case of massive transfusion, one should request the blood bank to give the fresher the better whole blood or pack red cells. FFP, this contains almost all the heat labile and heat stable clotting factors, and ideally to be stored at blood bank at -30°C. Volume is around 200 ml, and if after thawing, when it is issued, must be consumed within 4 hours, and the transfusion time should be 30 minutes in routine case, but in case of massive transfusion, it can be transfused fast. FFP routine dose is 1 unit per 10 kg body weight, and if the PT is less than, the INR is less than 1.5, then FFP we don't need usually. Cryoprecipitate, particularly it is the case require, it is the component of choice when the fibrinogen level is low, and it is very much needed in case of massive transfusion. Fibrinogen level is a good indicator for PPH severity. If the fibrinogen level is less than 2 gram per liter, then it has a 100% positive predictive value for the severe PPH. FFP transfusion is not optimal agent for treating the fibrinogen deficiency, as a volume of 30 ml per kg is necessary to increase the fibrinogen concentration of 1 gram. So when the fibrinogen is less, the product of choice, the component of choice is the cryoprecipitate. Platelet concentrate. The volume is around usually 50 to 70 ml. And in case of massive transfusion, the trigger point at which the platelet is required by the patient is 50,000 per kg per cubic millimeter. And the therapeutic dose in routine cases, it is 1 unit per 10 kg body weight. But ideally, in case of PPH, one should give the pack of 6 RDPs or 1 SDP, single donor platelet, apheresis platelet. This is just the kind of massive transfusion protocol. Like in randomly, we as a kind of thumb rule, we give this red cell plasma platelet. But if we want to specifically understand the actual need of the how much plasma or how much cryo or how much platelets to be given, one can take the help of the thromboelastograms like TAKE or ROTAME, and these are the parameters which are measured through these thromboelastograms and which can ideally tell us how much plasma, how much cryo, and how much platelet should be transfused to this particular patient. And these are the various graphs. In this talk, we cannot go into the details of that. Blood ordering in obstetrics, if there is low risk of transfusion, blood typing and testing of ABO system and an RS system is the only recommended. If there is a moderate risk, one can type and screen and give the transfusion. But in case of high risk, one should give the ORH positive blood. And this is the massive transfusion protocol. I don't think it will be. Is it whether the slide is visible at your end? Yes. If there is a high risk of uncontrolled bleeding, medical team should be activation should be done. Laboratory tests should be done like PT, PTT, fibrinogen, TT, and D-dimer, CBC, and ABG. And transfusion services type and screen must be advised. Immediate transfusion, if it is not needed, the conventional resuscitation should be done. And if it is required, activate the anticipate the total RBC requirement of more than 10 units. Need massive transfusion protocol? No, then give the components as per the lab results. But if it is needed, then activate the massive transfusion protocol with 6 units of red cells, 4 units of FFP, and 1 unit of SDP. Again, do the PT, PTT, fibrinogen and CBC. If INR is more than 1.5, give again the FFP to repeat the INR. If the platelet count is less than 50, give SDPs. If the fibrinogen is less than 250, give the 10 packs of cryo. If there is a lab results within normal limits, if yes, activate the ongoing bleeding, anticipate the ongoing bleeding. If no, repeat the initial MTP protocol and again repeat the protocol, the like FFP, red cells and platelets. And repeat the labs every 20 to 30 minutes. And if everything patient stabilizes or the lab parameters comes normal, you can deactivate the massive transfusion protocol. Massive transfusion protocol includes the transfusion packages and the intervention algorithm, which we have already discussed. This is the O negative 6 units and AV plasma and SDP, which are already discussed. And usually the fibrinogen level during pregnancy goes up, maybe up to 3 to 5 compared to the routine one. So the fibrinogen level must be tested and is very important. Otherwise, you should for the cryoprecipitate transfusion. This is about like massive transfusion protocol, but also we should also look into the blood safety. Better blood products like apheresis, leukodepleted, RBC with the additive solution or phenotype samples or NAT tested blood samples. Apheresis, if we see compare the rates, say random blood platelet concentrate, RDPs or SDP, SDP has lot many benefits and it's the ideal platelet therapy. In Western countries, it is the first line of platelet therapy. And 1 unit is expected to give the increment of around 50,000 platelet count in the patient. It is already leukodepleted, prevents the multiple donor exposure, like in case of random donor multiple platelet concentrators. Leukodepleted product is again a safer product as far as the blood component is concerned. Whatever grouped and cross-matched blood we give to the patient, following all the best possible practices at blood bank, still we do come across some kind of transfusion reactions, and majority of these transfusion reactions to the tune of around 7 to 80% are because of the WBCs present into the blood component. But if we give the leukodepleted blood components, these transfusion reaction, majority of them can be taken care of. Leukocytes can cause the febrile reaction, illumination, platelet refractory race, and all these problems, CMV transfusion and all. So these are, in Western countries, many Western countries, they have adopted the universal leukodepletion. But in India, because of the cost constraint, we do select the selective leukodepletion. But when the patient is affording, one should ideally go for the leukodepleted products. Phenotype, antibody screen blood, it must be given. It should be preferably given, but then that in massive transfusion protocol, it is practically not possible. I will try to skip these particular things. Transfusion risk. Whatever blood component we give, there are 2 types of risk associated with each blood component. That is, one is reaction, transfusion reaction, and TTI, transfusion transmitted infections. And unless the benefits outweighs the risk, one should not transfuse the patient, take a decision to transfuse the patient. And these are various transfusion reactions like allergic, febrile, hemolytic, TRALI, reverse TRALI, anaphylaxis, cardiac overload, dyspnea, and TAGVHD, graft versus host disease. And these are various infections which can be transmitted through blood from donor to the patient, like viruses and bacteria and parasites. In India, these 5 tests are mandatory for each donated blood to be done. But then even after careful testing by the government approved test, is it safe 100%? Unfortunately, no, because there is a risk of passing 1 in 800 tested blood. There is a risk of passing blood to the infection to the patient. And these are various TTI cases that happen, including AIMS and all. And various hospitals are heavily penalized under Consumer Protection Act. And these are the penalties right from 25 lakh to 95 lakhs.
The slides are not moving.
Oh my God, again.
Massive transfusion protocol. Last slide is massive transfusion protocol. No, it is moving.
Okay. So like blood safety, we have to, there are two kind of risks involved, the reactions and the infections. These are the various, unless the benefits are always the risk, one should not transfuse the patient. These are various reactions and infections which can be passed through the patient to the patient through blood, like viruses and bacteria. And 5 tests are mandatory, but even after complete testing, careful testing, the blood is not 100% safe. And in India, there is possibility of missing the infection in 1 in 800 if we do the routine tests. And these are various litigations as far as the infection is concerned. And many hospitals are heavily penalized under Consumer Protection Act, right from 25 lakh to 95 lakh. And if the TTI is the risk, NAT is the solution, just not for the patient, but also for the doctor and hospital safety. Why there is a risk of infection? Because of the window parade. In case of hepatitis B, occult B infection, Hep B infection, and technological limitations of the screening tests which are done at the blood bank level. And this is the immunodynamics of any viral infection like HIV, HBV, or SCV. I will try to go through quickly. After the blood, a virus enters the bloodstream or the any person, immediately it goes to the target organs. Like in case of HIV, it goes to the lymph node, or hepatitis B or hepatitis C, it goes to the liver. After initial multiplication in these target organs for a few days to weeks, then it appears into the blood. Till that time, the person, though infected, is not infected because the blood virus is not present in the bloodstream. And that particular period is called as the eclipse phase. After that, the virus enters the blood, then antigen, and then antibodies. The laboratory test detects the antigen and antibody, but then there remains the window period during which there is a risk of like passing the infection to the patient, and which can be taken care if we do the very existence, if we do the testing of the very existence of the virus by doing by the molecular test or by the genes test. That is the nucleic acid test. It is a molecular lab or genetic lab. It is a very high-tech lab, detects the genes of the virus, HIV, HBV, SCV. And there are 3 types of NAT. That is ID-NAT, that is individual donor nucleic acid test. The MP-NAT, that is a mini pool NAT, where the 6 samples are mixed together, and from this one mini pool, 1 NAT test is done. But it is inferior to the ID-NAT in a sense because of this pooling. There is sample dilution and the sensitivity of the assay drops, and there is chances of missing the infection. And the third type is the homebrew NAT. Here again, the quality standardization is a big concern. And the best is to go for the ID-NAT tested blood. Whenever you give the blood, you must consider the relative or the patients and take the informed consent. These are the various counseling protocols being provided by the NACO or NBTC, and the consent format given by the NACO. And informed consent is must. One-time consent is must is sufficient for the multiple transfusions during one admission, and medically legally it is mandatory in view of the Consumer Protection Act. But if it is a massive PPH where there is a it is most unpredictable situation the gynecologists or obstetricians face, this informed consent may be waived off. But then you should definitely tell your assistant to obtain the informed consent from the relatives parallelly. And it must be documented with the witness into the case paper. And this is the blood requisition form. Emergency issue, one should update, call telephonically the blood bank to issue the blood within 5 minutes for the emergency purpose. And blood bank can issue without grouping, cross-matching O negative blood, or if that is not available, O positive blood, and then start doing the actual grouping of the antibody screening and actual final cross-matching and all. If the blood, while transfusing the blood, because you have to transfuse the blood very fast, in that case, you can use the blood pumps, but then you should, or the infusion under the pressure through the small blood needles. If the pressure is more than 300 mg of Hg of mercury, then there is a chance of hemolysis. So ideally, the pressure should not go more than 200 mm of Hg. One should also use the warmer, but then mind well, the temperature of that particular warmer of apparatus should not go more than 42 degrees centigrade. Otherwise, that will also cause the hemolysis, and the patient may end up into the hemolytic reactions. Warming, ideally the warming is not required, but in case of massive transfusion, it is required. Rapid transfusion. These are the kind of blood warmers you can one should use ideally. Pre-medication ideally should not be given to the patient, because those will mask the transfusion reaction. If at all those are going to come and the patient is not, the blood component is not compatible to that particular patient, except Lasix or diuretics one should give if there is a risk of the cardiac overload, TACO, transfusion associated cardiac overload. Apart from Lasix, one should not give the pre-medication which will mask the transfusion reaction, like antihistaminics or steroids or antipyretics. No medication should be added into the blood bag, or maybe transfused to the T cannula also. Like electrolytes, ringer lactate may do the clotting. Dextrose may hemolyze the red cells. Hypotonics or hypertonic saline should not be given, or none of the drug should be mixed with either blood bag or into the cannula BT set. And if there is some reaction, we really will not be able to know because of which, whether it is because of drug or the this thing blood. Except normal saline or albumin, one can definitely add. This is no directed transfusion should be ideally given to the patient in view of, if we give the blood relatives blood, the chances of TAGVSD, transfusion associated graft versus host disease is there. Chances is 1 in 1,000, 0.1%. But if at all it occurs, then mortality rate is close to 100%. I think we can, if there is a scope for 5-10 minutes, we can go for the try to cover the transfusion reaction in short. Okay. Usually transfusion is safe. Sometimes there are some reactions do occur. Some are mild, some are moderate, and some are severe and life-threatening also. These are various signs, symptoms of the transfusion reactions. And these can be acute or delayed. Acute, those which occur within 24 hours. Delayed, which occurs after 1 day, 24 hours. Those are immune mediated and non-immune mediated. And it can be classified as per the clinical presentation as a mild, moderate, severe, or delayed one. Allergic is the most common. Second is the febrile reaction. Third is the anaphylactic. And such kind of reactions happen in case of the patients who are having the IgA deficiency with the preformed IgA antibodies. Such patients can land up into the severe anaphylactic transfusion reaction. There, if at all patient requires the blood, has to be transfused with the saline washed blood components. Plasma cannot be given in such cases. TRALI. Plasma can cause TRALI because of the anti-HLA antibodies. There is a clumping of the WBCs in the pulmonary circulation and leading to pulmonary edema. TAGVSD, I already told you, and hemolytic reactions. is the serious thing which one can ever face. That is nightmare for clinician as well as the blood transfusion experts. These are various signs and symptoms: fever, chill, rigors, hypotension, respiratory distress, pain at IV site, oozing from the IV lines. During surgery, diffuse oozing, hypotension, or hemoglobinuria may be the only signs. Oliguria, anuria, and shock are the presentations. And in the non-immune causes of this hemolytic transfusion reaction can be bacterial contamination, thermal exposure to RBCs, or mechanical hemolysis. Chemical effects, hyperkalemia, or contaminated or hemolyzed blood transfusion can cause these hemolytic reactions. These are various DDs: rash, breathlessness, and management. Management depends on whether upon the clinical presentation, when it is mild, moderate, or severe. Mind you, whatever like serious hazards of transfusion reactions they occur in initial 10 to 15 minutes or 30 minutes. So the initial transfusion must be under the direct supervision of the transfusionist. Category 1, mild, like itching and rash. Management: slow the transfusion and give the antihistaminics. If the patient recovers within 30 minutes, okay. If not, treat as a category 2. These are the various signs, symptoms of moderately severe transfusion reactions: itching, anxiety, headache, palpitation, mild dyspnea, flushing, urticaria, restlessness, fever, rigor, tachycardia. And the causes are hypersensitivity or febrile reaction. Here, in case of moderate, you have to immediately stop the transfusion, replace with the IV set, keep the IV line open with the normal saline, and notify the doctor and the blood bank immediately, and send for the investigation, the BT set and the blood unit, freshly drawn blood sample from the opposite side, opposite hand, and along with the transfusion reaction form. Give the antihistaminic, paracetamol, and steroid and bronchodilators if there are anaphylactoid features like bronchospasm or stridor. Maintain the urine output. If there is a clinical improvement, restart the transfusion slowly with the new blood unit. If there is no improvement within 15 minutes, should be treated as a category 3 or life-threatening or severe reaction. These are various signs, symptoms. Management is again: stop the transfusion, give the saline, airway, maintain the airway, give the oxygen, adrenaline, steroid, bronchodilators, diuretics. This must be done by the transfusionist RMO or the nurse itself. Then inform the doctor and the blood bank immediately. Send the things for the investigation of the transfusion reaction. Check the fresh urine for the hemoglobinuria. Maintain the fluid balance. Reassess the bleeding. If required, give the platelet and plasma. Reassess if hypotension persists, give the normal saline or dopamine as per requirement. If the urine output falls, maintain the fluid balance, give diuretic, dopamine, or dialysis if required. If the bacteremia is suspected, give the broad spectrum antibiotic. And the main cause for this severe reaction is the clerical error: wrong blood in tube while identifying the patient and mislabeling the tube, or giving the wrong blood unit to the wrong patient. So one has to be very careful while transfusion and taking the blood sample. This is my kind of presentation about like various transfusion protocols in PPH. Over to the chairpersons.
Sir, thank you, Dr. Harish Varve, sir. Wonderful lecture indeed. You have given all the ideas regarding transfusion reactions, what we should do and when component should be advised, because it is unnecessary, like crime giving whole blood when it is not needed. So wonderful lecture. And secondly, I like the various tests you have given, because we know only about cross matching and hemoglobin and CBC, etc. But the test can be done on the patient's blood or donor's blood. So it will be available within 10 minutes, because sometimes we don't have time. So we ask for blood, but they say sometimes half an hour is required. But that half hour is very precious time for us. So 10 minutes blood can be given to the patient. It's very, very wonderful information. And secondly, as far as medical legal problems are concerned, I have witnessed 2 patients where wrong blood was given to the receiver, there was some case against that particular doctor. But somehow there was no mortality. But you can imagine what must have happened to the doctor when he came to know that wrong blood was infused to the patient. But somehow the department was very cooperative and somehow they handled the case very efficiently. Otherwise, it was a crime to give wrong blood to the recipient. So wonderful lecture and wonderful information by you. Thank you very much for accepting our invitation. Thank you, sir.
Thank you so much, sir. It was actually an eye-opener. It was actually an eye-opener for all of us. Thank you very much.
Thank you. Thank you.
We would like to know if there are any questions. Dr. Rajasri, have you got any questions?
Yes, actually, I have a couple of questions. I'll just take it.
The one question is that previously what we used to do is to warm up the blood with cotton and everything. So nowadays we ask for the room temperature, keep it at room temperature and can be given.
Rule of 30 must be followed. Blood transfusion must be started within 30 minutes of receiving the blood. So that and warming is absolutely contraindicated, except 4 contraindications, where 4 indications, like exchange transfusion, massive transfusion, when there is a cold antibody, or when we are transferring to the central line, because the cold blood will reach the SA node and may cause the cardiac arrhythmias. Apart from these 4 indications, warming of blood will cause more harm to the patient than doing any benefit.
So is there a time limit for platelets and plasma? If the plasma is given to the plasma, interval between availability and transfusion to the patient, platelets and plasma.
Plasma should also be transfused within 4 hours of issue, but as soon as we receive, it should be started, because the labile clotting factor will continuously keep on depleting unless if you delay the transfusion. So plasma is also to be transfused as soon as possible. And one more information about the platelet: you should never keep the platelet in the hospital refrigerator. Once its temperature comes down below 15 degrees centigrade, though the platelet will be present into the bag, those will not be functionally fully active. So never keep the platelet bags in the refrigerator. Keep at the AC temperature, and every minute or 2 you should do the gentle agitation, and that should suffice.
Thank you.
Sir, there is one question. They wants to know which monitoring of which lab values is to be done during massive transfusion protocol.
Monitoring, I have already told you about, like the PT, PTT, hemoglobin, CBC, then fibrinogen, APT, thrombin time. Fibrinogen again is very important. These are.
So how frequently we should repeat this?
Every half an hour. Every half an hour.
And one more question is there. Please explain the role of FFP, PRP, and cryo, each one in obstetrics case, when to use.
In like FFP, if the PT is more than, if the INR is less than 1.5, you should never think of like giving any cryo or FFP. If the INR goes more than 1.5, yes, definitely one has to give the FFP 1 unit per 10 kg body weight, and give the therapeutic dose of 1 unit per 10 kg body weight. Unless you give the therapeutic dose and the clotting factor do not rise more than up to 25% of the normal range, it will not achieve the hemostasis. So giving 1 unit of FFP is giving like giving 150 milligram of paracetamol to the febrile patient, adult febrile patient. So whenever you give the blood component, you must give it to the therapeutic dose. For FFP, it is 1 unit per 10 kg body weight. For cryo, if the fibrinogen level is less, but the pack of 10, in case of massive transfusion protocol, pack of 10 of cryo must be given in one shot. The volume of cryo is maybe around 15 to 20 ml. So giving that is not big volume. But if the cryo is not available, then 30 ml per kg body weight, it is a big volume. It is going to be big volume problem, cardiac overload problem in case of in patient. That time one definitely has to use the diuretics and all.
Thank you very much, sir. When your talk was going on and there was a mention, I just remember that before 2 years in NEET PG, sir, there was a question on trolley.
Trolley, yeah.
Yes, sir. And the only incorrect option in that option was the use of diuretic. That was an incorrect option. So I just remember that there was a question on trolley in NEET PG exam.
See, trolley can happen when the plasma is given. When the antibodies are directed towards the patient WBCs, and those patient WBCs get clumped and trapped into the circulation. But there can be reverse trolley also, there wherein the cellular component from the WBCs from the donor blood unit are clumped by the WBC, the antibodies from the patient. So there that reverse trolley is, but reverse trolley is usually milder. The main trolley is because of the WBC antibodies into the donor plasma, and this is the reason why we don't use the plasma from the female donors, because female donors, they do have the irregular antibodies to the tune of around 2 to 5%, and the person who has received the blood transfusion, from them also we do not issue the give the plasma to the patient. Such plasma from female donors and those who have received the blood donor, we send it for the plasma fractionation and not issue to the patient to avoid the trolley.
Thank you very much, sir. That was a really very interesting, in-depth and a sort of an eye-opener talk for all of us. We are also thankful to respected Dr. Alka Kakade madam. She has chaired the session. On her request, she has come and honored us, and we wish all the best and success in all her endeavors in Foxy. Best wishes, ma'am.
Thank you all. Thank you.
Thank you. Thank you, Raj.
I would like to request Rajasi to propose a vote of thanks.
Yes, indeed. It has been an extremely stimulating and wonderful session again. In fact, as our flyer also says, I think the participation benefits of learning from experts, clarifying their questions, and practice changing updates is what is the take home and what sets this series apart from all the other CMEs and webinars. So friends,
you are
do
part
keep
of it. You are part of it.
Yes, indeed. I am really privileged and thank you so much for that. Friends, I would like you to keep tuned in for our future forthcoming sessions also, which we will always keep notifying you on WhatsApp and Gmail. For today's session, I would like to extend my thanks to respected Rajendra Singh Pardeshi sir, the President of AMOGS, and Dr. Sujata Dalvi ma'am, Honorary Secretary, for their unflinching support in all our educational endeavors. Also, today's speakers, Dr. Aniket Kakade and Dr. Harish Varbe sir, have done absolute justice, and they have been fantastic in their speeches, both of them. Really appreciate, sir, your time and energy that you put in for this session today. Thank you. Our chairpersons for today, Sneha Buyar madam and Alka Kakade madam, have, as expected, given their valuable inputs and shared their experiences, which adds a lot of worth to this academic sessions. Thank you so much, ma'am. I think Sneha madam had to leave because she had some work, but Alka ma'am is here. Ma'am, thank you so much for your inputs. Really appreciate it. And special thanks to the guides of today's, the conveners of today's sessions, Dr. Rashmi Kahar, Chairperson of AMOGS High Risk Pregnancy Committee, Dr. Sneha Buyar madam, Dr. Chaitanya Shembekar sir, Dr. Pranjal Sharma, Dr. Suyoga Panat from Amravati OBGY Society, the President, Dr. Anita Bobde, the Secretary of Amravati Society, and myself for being a part of this entire journey of learning. Code Blue is the emergency call when PPH starts. And I think through all our sessions, that's what we are trying to tell and help our obstetrician friends, that you dial Code Blue and all of this academics is going to help you along with your fellow obstetricians. So thank you so much. And with this, we would like to sign out. Before I forget, a special mention for Corona Remedies and COR Connect, who have been very valuable technical partners for all our series. Thank you so much.
Vashisht, that you are there. We are very much thankful to you. Vashisht.
Thank you. Thank you so much, ma'am.
Nice to
Thanks
see
a lot,
you.
ma'am.
Thank you.
very much.
Versus.
So have a wonderful evening, all the respected speakers and chairpersons and my co-conveners, Rajasri, and have a very good time. See you again.
Thank you.
Thank you. Thank you.
Bye.
You too. Bye.